They're my favorite too.
Yeah.
That's not something my favorite.
Like, I could an entire 3 pounds of them.
Well, because she said she knows, I know I'm wet, it's just easier for me to get here.
How do you do that?
I bet you just like separate it. And then you other together, but then I feel like there's one. 4 ounce could only work if I was telling you.
One of them did in the microseed lab.
Okay, so I just had to make sure that it was there. That's you, yes. I just had to make sure. This morning's lecture is going to be labeled as 10:20:16 a.m. under recordings on Nurse 324. So for your, I don't know if it's listening pleasure, if you like that droning mosquito in your ear. I do want to, let's see, let's pull up a couple of things here.
And I don't have vitals or anything like that.
So instead of all of this being written out,
And I don't have, I have hardly anything on that.
Oh, she likes to get.
I have one, but mine's a pressure.
That happened with everything.
oh, you have to pull it. Hi, Sam. We're going to be doing your routine checkup today.
This one is verapamil. You ready to go to confession on public? Oh, sorry, I thought I turned it up.
Pretty high.
Did I give it a brain freeze? Come on, here we go.
Well, health time, I got 148 over 92. Pretty high. So Tim, reviewing your results, you have, it appears you have an elevated blood pressure, so let's take a look at your daily living activities. Can you describe what happens on a typical day for you?
Usually I sleep in about 10:30, 11 o'clock. I have class at noon. After that, I usually just go home. Do homework, play video games.
Okay. What does a normal day's meals include for you?
For breakfast, I usually go to McDonald's. After school, I usually just snack on some Doritos or something when I'm playing video games. I really like salty food.
Tim, on an average, how much alcohol do you consume?
I have a few beers a day.
Okay. Do you use tobacco products?
Every once in a while.
Okay. And do you have a history of high blood pressure in your family?
Yeah, my mom.
Alright, so since this is a new onset of elevated blood pressure, we're going to start with just adjusting some of the areas in your daily living activities. So first, I'm going to suggest that you get at least 30 minutes of physical exercise every day. Next, let's look at your diet. Try limiting your sodium intake by requesting no salt on your fries. Also, make sure you're intaking adequate amounts of vitamin D and potassium. Another adjustment you can make is by limiting your alcohol intake to 24 ounces of beer a day, which would be 2 12-ounce cans. You should also try avoiding tobacco products because smoking and chewing tobacco immediately raises your blood pressure. So we'll check back at your follow-up. Hi Tim, we're going to recheck your vitals and see if any of the adjustments we made help, okay?
Yeah.
Okay, Tim. I got 144 over 92. So your blood pressure is still high. Do you currently take Cividine or ranitidine?
I do not.
I'm going to prescribe you verapamil to see if that will help. Okay, Tim. So I prescribed you verapamil. It's also known as Veerlan, and it's a calcium channel blocker used for your hypertension.
Okay. How's that going to help?
It works by relaxing the muscles of your heart and your blood vessels. You'll frequently have to get your blood pressure and your vitals checked, and along with liver and kidney function tests as well. You'll need to be careful of changing your positions and standing up because orthostatic hypotension may occur as well. It also can cause constipation, so make sure you're getting adequate amounts of fiber and fluid each day. And if any of these occur, come in and let us know and we'll check it out for you. And you may also take your verapamil with food.
Okay.
There's your education for you. All right, 120 over 80, that's perfect.
Perfect. If you have any adverse effects of verapamil, consult your doctor immediately. These adverse effects could include orthostatic hypotension and peripheral edema, constipation, suppression of cardiac functions, including bradycardia and heart failure, dysrhythmias, acute toxicity resulting in hypotension, bradycardia, AV block, and ventricular tachycardia. Pregnancy risk category C, so do not use in pregnancy when possible. Verapamil is contraindicated in clients who have hypotension, heart block, digoxin toxicity, severe heart failure during lactation. Use cautiously in older adults and clients who have kidney or liver disorders, mild to moderate heart failure, or GERD. Verapamil can lead to digoxin toxicity. Concurrent use with beta blockers can lead to heart failure, AV block, and bradycardia. Consuming grapefruit juice is contraindicated while using verapamil. Do not crush or chew sustained release tablets. Advise clients to change position slowly and to avoid activities that require alertness until effects are known.
If you need a blood pressure pill, take verapamil.
Yeah.
Lots of good information in that commercial there. And we'll also do lisinopril right away. Since we're in the midst of those medications.
When I found out the effects that high blood pressure could have on my life, I asked my doctor what I should do. He recommended lisinopril.
Lisinopril lowers blood pressure by specifically inhibiting the angiotensin-converting enzyme. This improves cardiac output and exercise tolerance. You may use lisinopril alone or concurrently with other classes of antihypertensive drugs. Continued compliance with lisinopril is very important. If you miss a dose, take it as soon as possible, but not too close to your next dose. You should not use lisinopril if you have a history of angioedema related to treatment with an ACE inhibitor, have a hypersensitivity to ACE inhibitors, or are pregnant or nursing. The use of indomethacin and other NSAIDs may decrease antihypertensive effects of lisinopril. If you are on a lithium-containing drug for treatment of another disorder, lisinopril will increase your risk of lithium toxicity. Consult your doctor before use for children younger than 6 years of age or if you have impaired kidney function, renal artery stenosis, renal disease, renal failure, or hyperkalemia. Use of this drug may not be permitted. It is important to restrict the amount of sodium and potassium consumed while on lisinopril. If you experience any hoarseness, swelling of the face, mouth, hands, feet, or sudden trouble breathing after using lisinopril, you should discontinue this drug and contact your provider. Notify your provider promptly of any indication of infection, such as sore throat or fever. Do not drive or engage in other potentially hazardous activities until response to the drug is known. Ask your doctor if lisinopril is the right choice for you.
When I found out I had high blood pressure, I visited my doctor. He told me that lisinopril would increase my cardiac output and exercise tolerance. I knew it was the right choice for me. Your high blood pressure will chill on lisinopril.
I like them. They're pretty good. Lots of good information in those commercials. If you catch it, some of the information on those commercials is exactly what I was kind of shouting about this morning about making sure the kidneys are working before you give those medications, but not helpful. So, yeah, I was like, I'm like, you love it.
All right.
I don't know.
Yeah,
Are you sure?
I was that kid that worked.
That's all right. Okay, we're back to our pharmacology made easy. Look to the right, look to the left. No, listen back there. Who else? There's 22 of you, yes? Oh, okay. Hope she's all right.
I know she said she.
Okay. As long as she's okay. Yeah. Tell you my horror stories another time. Right, 157 in our Pharmacology Made Easy book, page 157. Get your highlighters ready. We're doing centrally acting alpha-2 agonists. Specifically, clonidine is your prototype there. Under purpose, the expected pharmacologic action. I highlighted bullet number 2, which is a decrease in sympathetic outflow to the peripheral vasculature, which results in vasodilation. That's key. Which, when you vasodilate, you drop the pressure. Blood pressure goes down, and you have vasodilation. If you've got vasoconstriction, that means there's more pressure on those vessels. That's where you get the high blood pressure. But if you have vasodilation, your blood pressure usually goes down. Okay, so therapeutic uses, primary hypertension. I have never seen it used as for treatment of severe cancer pain. Again, if they're using it, that must be beneficial. Investigational uses, migraine headache, flushing from menopause, management of ADHD and Tourette syndrome, and also management of withdrawal from alcohol, tobacco, and opioids. And then for some reason, I wrote myself down a note down at the bottom of the page that said, review the parameters of normal blood pressures. What you just told me, what's a normal blood pressure again, please?
120 over 80.
120 over 80. You get a patient that has a blood pressure of 80 over 40, and you're prescribed to give an antihypertensive medication. Don't do it. Hold it. Very good. Very good, very good. Okay, page 158, beta blockers, which are beta adrenergic blockers. You will hear nurses say they're talking about beta blockers. And our beta blockers are metoprolol. These are the prototypes: metoprolol, propranolol, carvedilol, and labetalol. So the good thing about the beta blockers is most of them end in LOL. On page 158, under complications, way down at the bottom of the page, beta-2 blocker, blockade propranolol. Propranolol can cause bronchoconstriction. So if you have an asthmatic patient, way down at the bottom on the right-hand side, propranolol, bronchoconstriction, avoid giving propranolol if you've got a client with a history of asthma. Very important. Okay, we're going to go to page 159. Again, that beta-2 blockade, propranolol under nursing administration, which is on the right side of the page here for me. Nursing administration. I highlighted the bullet that says, teach clients to self-monitor heart rate and blood pressure at home. Most clients, if they're really compliant, meaning they're in on the program and they want to do better, they'll do it daily. And that's a cool thing. some busy adults maybe not won't do it on a daily basis, but just tracking, get that kind of diary of blood pressure and pulse going. Again, don't give these beta blockers if your patient's pulse is less than 60. You've got a patient with a pulse less than 60, stop. Don't give it. So you will find in the clinical setting when I'm helping you with medications, because I'm the person that takes the meds out of the they call it the Omnicell, I'll quiz you about what was your patient's blood pressure, what was your patient's pulse. And the reason I'm asking is don't give blood pressure medications to people who are hypotensive, and we don't give blood pressure medications to patients who are bradycardic. Okay, so when I get in the clinical setting and I'm like on you, like, what are they? There's a reason why. Okay. When are you going to hold those beta blockers? Pulse less than 60. Okay. Next one on page 159, which is medications for hypertensive crisis. So this is for big stuff. This is an emergency. Somebody's got hypertensive emergency. The med you're going to give is usually nitroprusside or nitroglycerin. And for the most part, when it is a hypertensive emergency, you're going to be giving these medications IV, so that it works right quick. So nitroprusside, nitroglycerin. We'll see nitroglycerin again in the chapter that talks about angina, but for the most part, nitroprusside, hypertensive emergency. Don't forget your application exercises on page 161. I'm going to point that if you're on page 161, I'm going to give you an example of how I could just love this question number 5, which is a static question. And the question is, a nurse is planning to administer a first dose of captopril to a client who has hypertension. Which of the following medications can intensify the first dose that can cause more hypotension? So you can pretty much pick out the other antihypertensives, right? So things like B hydrochlorothiazide, C clonidine, E aliskiren. So when you get into one of my exams, I might turn that totally around and say, a nurse is planning to administer a first dose of captopril to a client who has hypertension. Which of the following medications may not potentiate or may not intensify that hypertension? And in that case, you would choose simvastatin, which is a lipid anti-fat medication, and also phenytoin, which is a anti-seizure medication. So don't just memorize the answers. Kind of read the application rationale. Moving on, chapter 21, which is page 163 in your Pharmacology Made Easy book. Is it Pharmacology Made Easy? No, it's Pharmacology. Sorry. Cardiac glycosides and heart failure in chapter 21. So we're going to talk about the heart. Heart is a 4-chambered pump, like the oil pump in your car. It's like, tell me another pump that functions on water. Like it's like the aquarium pump that circulates water. So you've got an effective pump. And for the most part, it does a good job. It circulates your blood volume in an adequate manner. But if you've had a heart condition, if you've had a heart attack, or there's damaged muscle, if you've damaged your heart from tobacco use, from diabetes, from alcohol abuse, from substance abuse, all of a sudden, that heart may not pump effectively. And that's sometimes called heart failure. There's also heart problems where the firing mechanism isn't coordinated like it should be. So, cardiac glycosides, heart failure, if your pump isn't pumping well anymore. Okay, there's problems with it, which results in, highlight this, decreased tissue perfusion. Decreased tissue perfusion results in fatigue, shortness of breath, weakness, and activity intolerance. Tell you what, every fall when I come back to campus and walk up to the 3rd floor, I think I've got heart failure because I'm just out of shape. But by the time we get to this part of the semester, I'm pretty good. But in real heart failure, it's not just a matter of you're out of shape. Your heart has damage, okay? Heart failure, next paragraph, heart failure causes a reduction in cardiac output, affects the heart rate, the volume that it's circulating, it's called stroke volume, preload and afterload. And there are 2 types of heart failure. So left-sided heart failure, when you've got left-sided heart failure, think lungs. Lungs left. So patients will have dyspnea, shortness of breath, cough. And oliguria is little urine. So if you have right-sided heart failure is more systemic. So think peripheral edema. Their feet, their ankles are swollen. Jugular vein distension. Veins on their necks, below feet. Huge. Honk it out. And weight gain. Okay? So you'll use the left-right heart failure. Have you done cardiovascular in health concept?
Yeah.
Little?
In health assessment.
In health assessment. Oh, very good. Ah, very good. So take your book along when you do health concepts next semester. This will be helpful. Okay, cardiac glycosides, digoxin. Also known as lanoxin to some people, digoxin. When patients ask you what is digoxin going to do for you, I say it slows your heart rate down and it makes it beat more effectively. You can look at the fancy purpose down here, the positive ionotropic effect and the negative chronotropic effect, but essentially it slows down the heart and it beats better. So, therapeutic uses, up at the top of page 163, heart failure, dysrhythmias, meaning atrial fibrillation, firing is not even, complication. The big concern when we give clients digoxin, nursing consideration under dysrhythmias, conditions that increase the risk of developing dig-induced dysrhythmia include hypokalemia, results in, and also that usually goes right along with it, increased serum dig levels and heart disease. So that's why when we're given dig, we have to know item number 1, 2 under nursing considerations. Monitor your patient's potassium level. They're hypokalemic, they might be getting dig toxic. Don't. Dysrhythmias. And item number 3 under nursing considerations, instruct your clients to report manifestations of hypokalemia. Well, we've heard that before in a chapter or 2 behind. Nausea, vomiting, general weakness. God bless you. Potassium supplements are prescribed if clients are concurrently taking a diuretic. And again, teach your clients to consume high potassium foods. Green leafy vegetables, bananas, potatoes, dried fruits. High potassium foods, you two know. GI effects of digoxin as a complication, GI effects include anorexia, which actually also happens to be usually the first manifestation of toxicity, nausea, vomiting, abdominal pain. One of the unique things about digoxin is what they call halos. It's listed under CNS effects here. Weak vision changes, diplopia, blurred vision, yellow, green, or white halos around objects. That seems to be one of the kind of classic things for digoxin. Okay. Moving on to page 164 for digoxin. At the top there, interactions. Diuretics. Woo-hoo! Diuretics can lead to hypokalemia, which increases the risk for developing dysrhythmia, meaning your heart isn't beating right. It's irregular. It's getting beat. Dysrhythmia means it's not rhythmic, right? So diuretics are especially notorious for causing that hypokalemia. Nursing consideration. How many times did I highlight this? Must be important. Monitor the potassium. So we know that diuretics can cause hypokalemia, but the next item down, ACEs and ARBs, actually increase the risk for hyperkalemia. Yeah, Karen? It's just the way it's produced, where it's bonding, where it's making it more dissolvable, available, metabolized. Yep.
More stable as a compound.
Oh, that's hard. From a chemistry person. So diuretics, some, especially the loops, like furosemide, they can cause hypokalemia, but ACEs and ARBs can cause hyperkalemia. Okay, moving down the page, page 164, nursing administration. Check pulse, item number 2 under nursing administration, check pulse rate and rhythm before administration of digoxin and record, notify the provider if the heart rate is less than 60 in an adult. I won't quiz you about children or infants, but I've given dig to tiny babies with heart problems before. Yikes, guys. Is there an upper limit on the pulse? That is such a good question. Is there an upper limit when we should not be giving digoxin to our patient? Specifically, some of these cardiac medications that are supposed to control the rate and rhythm. So if you've got somebody whose baseline heart rate on digoxin has been 72, 88, 76, 70, check again, 90, check again, 120, it's like, call somebody, because that means your digoxin is not working. And they'll probably check a level and figure out if there's something else. If they have an infection, something's cooking. But don't give it if it's less than 60, but if it's all of a sudden, varying from your baseline, like it's going up the tree, it's like something's going on. Assess your patient, do vital signs, give your provider a call. Okay, page 164, bullet 1, 2, 3, 4, 5, 6. Instruct the clients to observe for manifestations of hypokalemia. And then the next item down is instruct your clients to observe for indications of digoxin toxicity. Fatigue, weakness, vision changes, GI effects. Notify the provider. Also on page 164, here's, I know I love an antidote. Management of ditch toxicity. It's called digoxin immune fab, which is the last bullet under management of ditch toxicity. Overdose is activated charcoal. Remember, activated charcoal is going to absorb as much of the toxin as it can, or the medication. And then usually the laxative in the activated charcoal is going to help get it out of the body as quickly as possible. But then you also may be giving something called digoxin immune fab, also known as Digivine. That's just like a brand name. So we'll stop. Page 164, our adrenergic agonists. Our select prototype there is catecholamines, specifically epinephrine and dopamine. Trying to say if there is anything that I needed to say about that. Epinephrine, dopamine usually have the opposite effect from, they don't cause vasodilation, they usually cause vasoconstriction. They cause more rapid heart rate. So, is there anything else there? Nope. That is all for that chapter. Don't forget your application exercises on page 157.
So epinephrine, like,
yeah?
Why would we want to?
Because usually during an anaphylactic allergic reaction, you have like hypotension. People's blood pressures drop. They may get the fluid leaves the vascular system and goes to edema. So blood pressure drops. So then you got to give epinephrine to try and cause a little more vasoconstriction. So you're circulating blood to the vital organs. And then you also give things like antihistamines to decrease the swelling. We'll keep the airway open. Okay, so next is page 169, chapter 22 is angina. Angina, wherever you come from, it's chest pain, right? Okay, pain manifestations as sudden pain under the sternum radiating to the left shoulder, arm, and jaw. The reason that happens is the heart muscle isn't getting enough oxygen, not enough blood flow, not enough oxygen. So, interestingly enough, not every patient will experience angina, chest pain in the same way. Some patients may come in and say, my left ear is killing me. Some patients will come in and say, my left hand is totally numb. I can't feel it. It's been hurting all day. Some patients will come in and say, I've got this pain in the left side of my back. I can't believe it. And it's really associated with decreased oxygenation of the heart muscle. So don't always brush off your clients. These are typical types of symptoms, but we know that women experience chest pain in very different ways. We know that diabetic neuropathy can also affect the way people experience angina. So just always be aware. Okay, page 169, organic nitrates. Here's our nitroglycerin again. Other medications, I'm going to draw attention to the isosorbide dinitrate and the isosorbide mononitrate. The expected pharmacologic action of your nitroglycerin is supposed to dilate veins, decrease venous return, and decrease cardiac oxygen demand. So it's going to open the blood vessels and promote more oxygen blood flow. And another way that we can promote that oxygenated blood flow, not that we're going to talk about it in pharmacology, but in nursing, applying nasal cannula oxygen to your patients, that helps enrich the blood so that when the veins are dilated, more blood, more oxygen is getting to the heart. Okay. The goal of using these medications for angina, the goal is going to be decrease the number of anginal episodes. So all of your nitrates, and later we're going to be talking about ranelazine, Renexa. Your goal is going to be decrease the number of anginal episodes. Complications on page 169, headache. Instruct your clients to use, it says aspirin or acetaminophen to relieve pain. I guess I wouldn't just be saying go use an aspirin right off the ding-dong. Acetaminophen, yes, we do give acetaminophen. But aspirin has this anti-platelet quality to it, make the blood thinner. Sometimes you can't exactly say take some aspirin when you know that they're maybe on some warfarin, Coumadin, already a blood thinner. So you got to be very careful. But acetaminophen is usually generic enough, you can give that. One of the ways you know that your patient's nitroglycerin, usually if it's given sublingually, it's a tiny little tablet, you put it under the tongue, the patient lets it dissolve under their tongue. And this nitroglycerin actually has kind of a short shelf life, so it's usually encouraged that it's kept very dry and in a light protected vial. But if you've had clients who've had their nitroglycerin on the shelf for 5 years and all of a sudden they put one under their tongue and they say, yeah, whatever, maybe not helping. The reason you know it's fairly fresh is most patients get a headache. That's an indication that it's fresh. Patients also say it's a little tingly under the tongue. That's another indication that it's fresh. That means it's working. But if they don't get a headache, if they say there's no tingle, you kind of wonder about the shelf life if it's been kept dry. So a complication of nitroglycerin, orthostatic hypotension. Make sure you're telling your patients after you take your nitroglycerin, don't jump up right out of the chair and run to the kitchen. Change position slowly. Another complication, reflex tachycardia. But again, for this, monitor vital signs, know your baseline. I have seen patients who are on isosorbides, mononitrates, that they give them a beta blocker, like a metoprolol. So sometimes they give them metoprolol to slow down that heart rate if they have the reflex tachycardia. The other concern with the nitroglycerin, the isosorbides, is patients actually develop a tolerance. So tolerance is a huge problem. It's very common. So the goal for that is start low as you can go. And if your patient is having good response, stay as low as you can go for as long as you can. You may need to increase the dose later, but start low. We used to give patients, we still do give patients nitroglycerin paste or nitroglycerin patches. So you'll put the patch on in the morning and you'll take it off at night. Or for this paste stuff, we would squeeze a tube on a little piece of paper, stick it on their chest, tape it there, and leave it on for 8 hours, 12 hours, and we take it off. The goal is to give your patient maybe like a little nitroglycerin-free period so that it helps prevent that tolerance, that buildup. So, interesting stuff. Okay. Next page 170. I think I already told you about the sublingual tablets, nursing administration sublingual tablets. Put the tablet under the tongue, let it dissolve. Tell the patients don't swallow it if they can at all prevent it. No huffing of your nitroglycerin sprays. There's a spray, a nitroglycerin spray that you can put it says translingual, so under the tongue they put a little spray, a nitroglycerin spray, but it's very concerning because it takes coordination, and if they're spraying and they're supposed to spray under their tongue and they're breathing in at the same time, it actually can become more systemic a whole lot quicker. Huffing, right? You know what huffing is? Nod your head. I hope you know what huffing is. Okay. So that's my words on sublingual tablets and sublingual sprays, and I told you how to determine if they are, if they're fresh. Okay, page 171. Anti-anginal agent, ranelazine. I think it's called Renexa, is it not? Brianne, my pharmacology tech. Ranelazine, Renexa. Anybody? Somebody Google it. I don't want to be wrong. It's ranelazine, Renexa. Oh. It is? Okay, very good. Ranelazine, Renexa. That's how I know it too. Okay, so ranelazine, Renexa, anti-anginal agent, interactions over on the right side of the page. Inhibitors of CYP3A4 can increase levels of ranelazine and leads to, it's called torsade de pointe. It's a rapid heart rate that doesn't circulate good blood. It can lead to dysrhythmia, okay? What else? Agents, so things like grapefruit juice, medications like HIV, some HIV medications, some antibiotics, antifungals, verapamil. We're just going to be really careful about medication history. So nursing consideration is avoid concurrent use. Also, ranelazine, concurrent use of digoxin, and simvastatin increases serum levels of dig and simvastatin. So again, you have to be really careful about medication history. Mixed in meds, polypharmacy, get in lots of trouble that way. And application exercises on page 172. Good stuff. Chapter 23, medications affecting cardiac rhythm. It is my goal to get through chapters 23, 24, and 25. If perchance we don't get through 25 by the end of our class time, I'll do the recording thing and I'll post it on TigerNet. I want you to have all of this before we hit Unit 5 exam. Okay, Chapter 23, page 175. So I just want you to highlight a few prototypes here. Antidysrhythmic medications, medications that are going to make the heart beat in a better pattern. Class 1A is procainamide. I'm not going to ask you to specify which class this medication comes from. And I just want you to be familiar with the names. So, procainamide. Class 1B is lidocaine. Class 1C, our prototype is going to be propafenone. I know flecainide, but propafenone. Class 2 medication, propranolol. It's an LOL. It's the beta blocker. Class 3 medications, amiodarone. Class 4 medications, verapamil, diltiazem. also known as calcium channel blockers. And then other medications for medications that affect cardiac rhythm, adenosine and digoxin. Adenosine is a fun med to give if you ever work in a clinical setting, in a heart setting. It's kind of scary. It's an adrenaline junkie's dream. Not to receive it, but to give it. It is, I'll tell you, it's kind of fun. 175. There's a couple of things that I want you to know about medications which affect cardiac rhythm. Space the medication doses as evenly apart as possible. Don't take one at 8 o'clock in the morning. It's not like a diuretic. Don't take it one at 8, the next one at 2. Try and take them at 8 and 8. Try and give them at 7 and 7. Try and give them at 6 and 6. You want a nice, even medication level in your patient. So space your doses as evenly as possible. Tell your patients, patient teach. This is not in your ATI book. Tell your patients, don't run out of these. It's best to get your prescription refilled before you run out. Now imagine how fun that is when you live in, give me a town that's 45 miles away. Rural South Dakota. So yeah, Deesmet's got a pharmacy. I'm thinking about the countryside. So teach your patients, don't run out of these medications. In the middle of winter, who knows, we might have a 3-day blizzard, and if you only had 3 days worth left of a medication that's going to control your cardiac rhythm, you might run out. If you run out, you're in danger. If your if your patient is ill and can't take their medications, if they're puking, if they've got diarrhea where nothing's staying in, they have to contact their provider because they might be a candidate for some other form of cardiac rhythm medication. So space your doses, never run out. If your patient's ill, call their provider. Page 176, way down at the bottom. Complications for lidocaine. Lidocaine complication is CNS effect, drowsiness, altered mental status, paresthesia, and numbness, tingly, funny feeling in the fingers and extremities, seizures. Carefully monitor your client and notify the provider if the manifestation occurs. After you carefully monitor your patient, before you notify the provider, stop the medication. Usually lidocaine is given IV, so stop the pump, stop the medication. I've actually seen this lidocaine CNS effect. It was the weirdest thing. On nights, in the ICU, it's crazy. Dear little old lady, but she was like totally out of it. So, stop the lidocaine. Okay. Also make sure if you are ever in a remote facility where you have to mix up your own lidocaine in your IV bags, make sure you don't take your lidocaine with epinephrine. Make sure it's plain lidocaine. Because if you put the lido and epinephrine in there, it's going to cause tachycardia, it's going to cause more problems than you need. So plain lidocaine is good for the heart. It's kind of a soothing medication. I say it works just the same way as it does. Like if you go to the dentist and get some lidocaine, kind of numbs it, soothes it, so it's not beating erratically. Okay, page 177, propranolol. Over on the left side of the page, propranolol can cause hypotension, bradycardia, heart failure. We're not going to get too much into AD block because we're not there yet. Fatigue, bronchospasm in clients who have asthma. That's second time I've seen that. It must be important. Nursing considerations, always, you're going to know a baseline. Monitor your blood pressure and heart rate. And here it says, notify the provider for a pulse less than 50 or other prescribed rate. The other prescribed rate when you get to the clinical setting is usually 60. So if you see that pulse that's less than 60, make sure you're holding your medication and notifying your provider. Page 177. One of the complications for amiodarone is pulmonary toxicity. Pulmonary toxicity for amiodarone. So for that, your patient is usually going to get, before they even started, they'll get baseline pulmonary function testing. It says obtain a baseline chest x-ray and pulmonary function test. Okie doke, we're moving on. Oh boy, we are moving on. Page 179. Here we are on the right side of the page again under nursing administration, lidocaine. Oh, I already gave away that one. Never administer lidocaine preparation that contains epinephrine, which is, Lido with epi is usually used for local anesthesia. And the reason you don't want to combine those two medications is because severe hypertension or dysrhythmias can occur. Yeah, well, think about it. It's more localized. Yeah. But when you give lidocaine, it's usually IV, so it's like system 1. But lidocaine with epi used for a local block, like if you're repairing a laceration and putting in sutures, they'll use Lido with epi. And the reason they do that is the epi causes vasoconstriction, so there's not a lot of bleeding from the laceration. But again, you're never going to use Lido with epi for a local block for a circumcision, right? Yes? Right. Okay. Don't do that. Okay, next page 180. And I'm not going to tell you my crazy story about adenosine. We're going to save that for another day. Adenosine at the top right-hand side of the page. Adenosine has a very short half-life. So the good thing is adverse reactions are mild and last for less than a minute. And the other thing you should highlight is administration should be by IV bolus flushed with saline following administration. So if you ever get an opportunity to be in the emergency department for somebody who has a cardiac dysrhythmia where they're going to give some adenosine, you will find that because this medication has such a short half-life, they'll start a big, like 18-gauge IV in the left AC because it's the closest to the heart. And then they'll sit with you got to have everything ready. You got to have your adenosine in one hand and your saline ready to flush. You're always got your patient on your cardiac monitor, but they'll push the adenosine really fast. And then as soon as they take the syringe off, somebody will swab it and they'll flush it. They'll push it further into the system with a little bit of saline. And the reason that is because it's got a short half-life. You want it to hit the heart as quickly as possible. I always say adenosine is like, it shakes up the heart and says, stop that. And it really does look like that on the cardiac monitor. It just kind of goes like, whoop, and then it starts, hopefully, sinus rhythm again. And patients feel that. They say, like, ooh, it's kind of an awful feeling to them, like they die. You always have CPR stuff ready. You always got your emergency cart right there. Like I said, it's kind of an adrenaline kick, but it's not drugs for me. 180. Nursing evaluation of medication effectiveness is we want to see a return to the baseline ECG heart rate regular rhythm. And don't think that I don't stand there and say, please God, just this once. Please God, just this once. I say that a lot. Okay, don't forget your application exercises on 181. You guys doing okay? Okay, anti-lipemic in chapter 24. Page 183, anti-lipemics. We want to lower the cholesterol, lower the fat level in the body, right? So I'm just going to point out here, anti-lipemics work in different ways to help lower the LDL. So lower LDL, LLDL, lower LDL. I always had a hard time when I was being a nurse. It was like, so we got all these different cholesterol things that we're checking, HDL, LDL, VLDL, and it's like, which one do we want up? Which one do we want down? So L, lower the LDL. And then our goal is a higher HDL is a good thing. Okay? Second paragraph down under anti-lipemics. As always, we want a baseline. So prior to starting these medications, the client should have lab work, baseline levels of total cholesterol, LDL, HDL, and triglycerides. Because some of the anti-lipemic agents are hard in the liver. Also make sure you get your LFTs, liver function tests, get that baseline. So, still on page 183, the HMG-CoA reductase inhibitors. Just say statins, highlight statins. Be sure that you can pick out some statins. So, atorvastatin, simvastatin, lovastatin. The good thing is they all end in statin, but they're statin. Okay? The purpose for our statins on page 183 is going to be decrease or lower the LDL and VLDL. The other purpose of these statins is increase manufacture of HDL. Okay, on page 183, some of the complications, just highlight hepatotoxicity. We know what hepatotoxicity is, right? After all these different medications that we've gone through. Myopathy, meaning muscle aches. So sensitive that if you touch, I had a mother-in-law that she was on a statin for a while. She couldn't tolerate it because you just touch her arm. It would cause pain. So myopathy, pain, aches. Nursing considerations. Advise your client to report muscle aches, pain, and tenderness. I wrote myself a note on the side. Statins plus verapamil can cause increased chance of myopathy. Statins and verapamil, more chance of myopathy there. Page 184. Statins plus verapamil, increased chance of myopathy. Page 184. Nursing administration. Bullet number 2 under nursing administration. Administer lovastatin with evening meal. Other statins can be taken without food, but evening dosing is best because most of our cholesterol is emphasized during the night. That must mean if I stay up all night, I won't have any cholesterol. Nice try. All statins in the evening. Okay. Cholesterol absorption inhibitor on page 184. Ezetimibe. You guys can pronounce it. I would love it. Ezetimibe. We're gonna keep moving on. I have nothing highlighted under that one, but just know the medication given for cholesterol control. Page 185, bile acid sequestrant. Colcevalin. Bile acid sequestrant on page 185, colcevalin. So interesting stuff about some of these bile acid sequestrants. I'm going to point you over to nursing administration on the top of the right top side of 185, nursing administration. It says colestipol is also supplied in a powdered formulation. Advise clients to use an adequate amount of fluid to dissolve the medication. This will prevent irritation or impaction of the esophagus. I pretty much know that it's not just this colestipol, it's like all of your bile acid sequestrant. You always make sure they take it with adequate fluid. Otherwise, it's like a piece of cement that gets stuck in their esophagus. Always adequate fluids with your bile acid sequestrant. Page 185, nicotinic acid, niacin. Also a medication used to lower cholesterol and triglycerides. Complications for nicotinic acid, niacin. It's kind of hard on the tummy, so GI distress. But I think patients I have seen know more about the facial flushing. They'll come in and they'll be like bright red in their face. So facial flushing and feeling a warm tingling of hands and feet. Here it says client education. Advise client to take aspirin 30 minutes before each dose. Again, make sure it's okay with your provider. But they should be able to take some aspirin to help, alleviate some of those symptoms. The other beneficial thing when we're talking about medications affecting coagulation, aspirin actually makes your platelets slipperier, so there's less chance that they're going to throw a big old clot, embolus. Okay, page 186, the fibrates, the gemfibrozole. On page 186, gemfibrozole. Again, it's used to help control cholesterol. Interactions on page 186 for the gemfibrozole. Interactions with concurrent use. Warfarin increases the risk of bleeding. Obtain your baseline BT and INR and perform periodic monitoring. And advise your clients to report indications of bleeding, bruising, bleeding gums, and notify the provider if these occur. On page 186, the antisendonucleotide, epomersin. I did not highlight anything on there, but it's an anti-lipemic. Okay, we've got some lovely application exercises on page 187. Guys are doing good. Stretch. Does anybody do yoga? Do your strong warrior. Your stretch. Just let it out. Now one chapter to go. Here we go.
Doing good, Rox.
Chapter 25, page 191. Medications affecting coagulation. Some folks are dying. Anybody need sugar to stay awake? Come on. We can do this. Medications affecting coagulation. Medications affecting coagulation are used to prevent clot formation or break apart an existing clot. And the reason we want to prevent clot formation or break the clot that's already there is to increase circulation and perfusion. Because if we know our muscles don't get circulated, perfused, well oxygenated blood, muscle dies, and that causes pain. So the big one we're talking about is the heart, especially. Parenteral anticoagulants, heparin, highlight your heparin, highlight your enoxaparin. Enoxaparin, also known as Lovenox. And again, under purpose of expected pharmacologic action for these medications, prevent clotting. Therapeutic uses for heparin is prevent clotting. So when patients are having evolving stroke, pulmonary embolus, DVTs, low-dose therapy for heparin can be used for prophylaxis against postoperative venous thrombosis. And they say it's the lower extremity, anything from the waist down, if you're having surgery, because of the inactivity, because of a potential like swelling, edema of the tissues around it, it really slows down the blood circulation, which makes clot embolus formation more likely. So you'll see patients that are going to surgery, if they've been on a long-term blood thinner like warfarin, because you can't take warfarin and go directly into surgery, they'll have them stay off their warfarin for like a week, and they'll probably get like Lovenox shot so that they don't develop embolus. You'll see patients get Lovenox and enoxaparin after surgery to prevent blood clot. Okay, this low molecular weight heparin is the enoxaparin, Lovenox. I see the package in my mind. I think for the most part at HRMC, the package just says Lovenox. So enoxaparin, Lovenox, get used to one or the other. The low molecular weight heparins prevent DVTs in clients who are post-op, and it also treats DVTs and pulmonary embolus. So when you're sending some of your patients home, and they do go home with their Lovenox that they give maybe once daily or twice daily, I think I pretty much see it once daily, teach your clients signs and symptoms of a DVT. Swelling, pain in the lower extremity, muscle cramp. Teach them about that because it's important. Complications, heparin. Advise clients to observe for bleeding, increased heart rate, decreased blood pressure, bruising, petechiae. Petechiae are like little red freckles all over their body. Petechiae. Try and spell that in the middle of the night. Hematomas. It's like a bruise. Hematoma. Black tarry stool. Or BRPPR. Bright red blood for red. Crazy guys. In the case of overdose, stop heparin. There's an antidote. Administer protamine. Tell your patients to avoid aspirin. So consider all those things under heparin, hemorrhage secondary to heparin overdose. All that stuff, it's important. Heparin is usually administered IV, especially if there's like a DVT going on. If you are giving heparin IV, you'll put it directly in the IV closest to the site of insertion. If you're giving heparin subcutaneously, there might be a question that asks you, what size of needle to use? What length of needle? that should go way back to subcutaneous medication administration yet. For like somebody who's got a pulmonary embolus, somebody who's got a bad DVT, because you want to get that anticoagulant going right away. You don't want any more flaking up, or it should get wet. You don't want any more flaking off, and because it usually goes to the lung. If it doesn't go to the lung, it goes to the brain. They do, but it's more like prophylactic. It's like, that would be the evolving stroke thing. There's a place up here that says evolving stroke. That would be, yep, for treatment of TIA. They don't want it to get worse. Okay, so page 192, toxicity and overdose. There's a nursing consideration again. Administer protamine. There's your antidote, protamine. Enoxaparin is our next item down on page 192. Potential that it can cause hemorrhage. So again, teach your patients. Signs and symptoms of internal bleeding. Maybe they're brushing their teeth and their gums are bleeding profusely. That's a sign that maybe that enoxaparin is maybe working way too good. Then you got to worry about what else is going to bleed. Like if I fall and bump my head, you're going to have an intracranial bleeding. That's not good. So teach your patients signs and symptoms. Huge bruises on you. Let's see what else. Toxicity overdose, a little further down. Administer protamine. A lot of times when docs are working with patients who are getting blood thinners, they're not only worried about the CBC, how many red cells, how many red cells are circulating, they'll worry about the number of platelets. So for the most part, they're going to be really cautious, and I know this thrombocytopenia is way down here under the spondyloperitux, which I'm not familiar with, but the thrombocytopenia, providers will be very careful about using blood thinners, because if patients have thrombocytopenia, meaning low platelets, if they do bump themselves, bump their head, cut themselves, they don't have enough platelets to stop the bleeding. So platelet counts less than 100,000 might change your patient's plan of care. Page 192, heparin, under nursing administration, over on the right side of the page, nursing administration. Under heparin, read your labels carefully. Heparin is not dispensed in milligrams, it is not in grams, it is not in mils, it's always in units. It'll be heparin, 1,000 units per mil, but heparin is always in units. Heparin is one of those high-risk medications. Always have a second nurse check your dose. And that's another item here. Check dosage with another nurse before administration. Highlight those things. Okay, moving on, page 193. Oh, you get to do more patient teaching here for enoxaparin. Provide instruction regarding self-administration. Must be going to do a lot of teaching in this exam. Medications can be available in pre-filled syringes. For the most part, enoxaparin is always, Lovenox comes pre-measured for us. And then for subcutaneous injections, it tells you what size and length of needle to use. 25 or 26 gauge, half to 5/8 inch needle. So that none of the medication stays on the side. And the little 25, 26, kind of hard to suck out of a bottle if you have to. It's slow. We're always in a hurry.
I would just think that would
Air or pathogens, yeah. Those pathogens jump in there. Okay, page 193, we have oral anticoagulant, which is warfarin, also known as Coumadin. Expected pharmacologic action for warfarin: antagonize the vitamin K, preventing coagulation. So if you just want to highlight antagonizes vitamin K, prevents coagulation, essentially that's what it does. I'm not going to quiz you on the different factors that it antagonize, but the therapeutic uses are important. Treatment of venous thrombus, also known as DVT. Treatment of thrombus formation in clients who have atrial fibrillation or prosthetic heart valves. Prevention of recurrent MIs, transient ischemic attacks, TIAs, involving strokes, pulmonary embolus, PEs, and DVTs. These are all called embolic events. Okay, moving on. Page 194, interactions. This is still all on Coumadin here. 194. You know I'm a sucker for a pregnancy class.
Okay, so it's warfarin and Coumadin the same thing?
Yes. Brand name is Coumadin, warfarin is generic. Patients will come in and say, I'm taking rat poison. There's warfarin in rat poison. Causes rats to bleed to death. Bad for your karma. No. 194, contraindications, precautions. Pregnancy classification, pregnancy risk category X. Beware, beware. There are young people who are on warfarin. I'm not kidding. It's not like, it's only warfarin's only for old people. It's not. It's for young people too. Interactions. Interactions on page 194. Concurrent use of heparin, aspirin, acetaminophen, glucocorticoids, sulfonamides, parenteral cephalosporins increase the effects of warfarin. Therefore, it increases the risk for bleeding. So we know those medications can make the warfarin work even better, but then look down in the middle of the page on the left-hand side where it says foods high in vitamin K, such as dark green leafy vegetables, cabbage, broccoli, Brussels sprouts, mayo, and canola, and soybean oil can decrease the anticoagulant effect if they have excessive intake. Know your foods that are high in vitamin K. Because you will have to do maybe a question or some sort of teaching to your patient in exam 5. Nursing administration on page 194. Monitor the PT levels. Prothrombin time. PT, prothrombin time. So warfarin, you check the PT. Heparin, you check the PTT. Okay? They're two different tests. If somebody's going on an anticoagulant, you usually check both. But if you're watching heparin, you got to have a PTT for sure that day or that hour. But if your patient's coming in and they're on warfarin, think PT. Okay, so monitor the PT levels. A therapeutic level, 18 to 24 seconds. INR, international ratio, something. They go, depending on what facility you work in, PT INRs are very common. Therapeutic levels, 2 to 3. INR levels are more accurate. But again, I tell you, it depends on what facility you work in. Hold the dose and notify your provider if those levels exceed therapeutic ranges. Page 195. Direct thrombin inhibitors, dapagatrin. I didn't highlight anything, but know Direct thrombin. I'm not even going to make you select a direct thrombin inhibitor out of a list, but no, read the name. The more you're exposed to it, the more comfortable you're going to be in a clinical setting. Direct inhibitor of factor XA. Select prototype is Roxane. Okay, it's 196. Antiplatelets. Aspirin. I love the next one. ABC Mixmed. Antiplatelet glycoprotein inhibitor. Antiplatelet ADP inhibitor is clopidogrel. And the next prototype, intoxifilin. Your expected pharmacologic action for these antiplatelets, just highlight under purpose, prevents platelets from clumping together. Prevents clots. Makes platelets slipperier. Page 197, aspirin. Complications. Page 197, complications of aspirin, GI effects, nausea, vomiting, dyspepsia, heartburn. Dyspepsia, heartburn. So best that you should encourage your patients to probably take it with food. Use enteric-coated tablets, meaning they've got a little coating on them and they won't dissolve all in the tummy, go further into the system. It also says aspirin can potentially be used with PPI, proton pump inhibitor. But I'm always concerned, once you get your patient, here's another medication, put them on a PPI, and all of a sudden it's changed the acid balance in the gut. Are they going to be more susceptible to the damage? Who knows? Who knows? But aspirin has GI effects. Prolonged bleeding time, third item down, fourth item down, gastric bleeding. So if patients are on aspirin and it thins their blood a little bit, it irritates their tummy, and they get an ulceration of peptic ulcer disease. They actually can have a GI bleed. And GI bleed can either come up as coffee ground emesis. Everybody knows what coffee ground is, right? Coffee ground is that black, chunky stuff. It can also be bright red, copious amounts. So monitor for that. So it can cause gastric bleeding. Also monitor for bruising, petechiae, red, bright red, like freckles all over the body, especially on the trunk, on the chest and back. Tinnitus. Overdose of aspirin can cause tinnitus, ringing in the ears, hearing loss. If manifestations occur, withhold the dose and notify the provider. Page 198. Page 198, thrombolytic medications. Alteplase, also known as TPA. So all these things that we've learned about before, the aspirin, the warfarin, the heparin, those all prevent clot formation, right? This thrombolytic alteplase is the clot buster. Those other medications that we reviewed are not clot busters. Aspirin does not bust a clot. Heparin does not bust a clot. Warfarin does not bust a clot. TPA, alteplase, that breaks up a clot. Okay, so expected pharmacologic action, thrombolytic medications dissolve clots that have already formed. Now, I'm not going to get into the fine, nitty-picky stuff of clots that are just dissolved by conversion of plasminogen to plasmin. Just know it's the clot bust. Dissolves clots. The concern is on page 198 under contraindications and precautions for this clot buster. Item number 2 under contraindications and precautions. Because of the additive risk of serious bleeding, use is contraindicated in clients who have had any prior intracranial hemorrhage, like a hemorrhagic stroke. If the patient knows that they have an AV malformation in their brain, not many patients know that they've got an AV malformation in the brain, which is a known structural head lesion. Active internal bleeding. If the patient has had a significant history of closed head or spinal trauma within the past 2 months. Acute pericarditis, inflamed infected heart, endocarditis, inflamed infected inside the heart, brain tumors, severe hepatic or kidney disorders, and use cautiously in clients who have had severe hypertension, cerebral vascular disorders, recent GI or GU bleeding, or major surgery within past 10 days and in older adult clients. When this says use cautiously in clients who have recent GU or GI bleeding, normal menstruation is not a contraindication. There's specific GU gynecologic conditions where there's menometrorrhagia, meaning it's a excessively heavy menstrual flow. Those people, you have to be careful with alteplase. But normal menstruation is not a contraindication to alteplase. Because we've had a patient come in who is menstruating, having a heart attack, and we wanted to give her TPA. And we go through this little checklist. She was like, menstruating. I was like, Doc, what do you think? He was like, nope, not a contraindication. So normal menstrual flow does not kick you out of the alteplase use. I'll tell you what does send you out of the TPA possibilities. If patients have hemophilia and problems with just clotting as it is. So hemophiliacs should probably not be given TPA. But normal menstruation is not a contraindication. They can still have TPA. Oh, look, page 199, there's some lovely application exercise. Should we call it? Should we say amen, let us pray? Okay, yes. Take a break. Do you want to be done, or do you want to go through some practice questions? Oh, sure. We have no new medication math on exam 5, but it's pretty much everything we've done so far. It's like figuring doses, changing pounds to kilograms.
Hey, Rock.
Dose per weight.
Did we go over the dose? I'm thinking about alpha adrenergic factor.
Page again, please.
156. That's where we ended.
Oh.
It's just on our highlighted it. What's that? Yeah. No,
You know what? I don't think I highlighted anything on there.
Okay.
But it's good that you should know that prazosin is one of those medications that probably given for blood pressure.
Okay.
But again, I'm not going to put a huge list of medications up there and ask you which is your alpha adrenergic blocker. Not going to do it. Next spring of 2018? 2019. When do you graduate? In the spring of 2018, I might ask. Morgan.
The other day, yesterday, I think Becca had mentioned here on one, get all on the fair one.
Did she? Okay.
But we were just wondering, I guess my question is, next week after the test, are we gonna come back and review?
That is my question to you, actually. Do you want a little bit of a final review?
Yeah. Especially like over the, like, you know, the first two exams, like,
So-
you know, like, we don't get through all the way.
Right. So next, when are you guys going to Parkston to have the grand tour? Yeah, I think the grand tour of Parkston is supposed to be October 27th. So,
email out.
Yeah, but what time are we, because honestly, my final is my fireworks.
oh, no, not on prayer. You must attend Parkston.
Well, right, but do we have that time first, because if we can go to Parkston later.
No, I think you should go to Parkston on the 27th. I looked at my calendar and I thought, like, what are you guys doing on November 2nd?
We had
I'll send out.
time for Parkston yet?
I believe you
Can
do.
you just send out a good blueprint or something?
The 28th, we have a number of students going to run for their, like house students. Yeah. Hold on, guys. I'm going to stop this recording. If you want to go grab Megan and have her give us the, if she's available, don't interrupt. I know she's seeing a lot of students.